Welcome, everyone. We're going to give people just another moment to sign on, and then we'll begin. So welcome to the webinar, Brain Metastasis, Emergent Treatments and Reasons to be Hopeful, with our presenters, Dr. Nancy Lin and patient advocate, Julia Malice. My name is Christine Benjamin, and I'm the Breast Cancer Program Director at Share Cancer Support. And we are broadcasting today from New York City. But Julia is in DC, and Dr. Lin in Boston. So before the presentation begins, I would just like to thank our partners in collaboration, Living Beyond Breast Cancer and the Young Survival Coalition. Our three organizations are dedicated to providing information, support, and services for those diagnosed with breast cancer. And each organization has unique programs dedicated to serving women and men living with metastatic disease. Please visit the websites of Living Beyond Breast Cancer at lbbc.org and the Young Survival Coalition at youngsurvival.org. And visit Share at sharecancersupport.org. So in a moment, you'll hear from Dr. Lin and Julia. And in the meantime, you're welcome to submit questions at any time during the presentation through the question tab on your control panel on your screen. At the end of the presentation, myself or Julia will compile the questions and read them to Dr. Lin. Please keep your questions general in nature, as Dr. Lin is unable to provide any specific medical advice during this webinar. So just a little bit of background. Julia and I had a conversation early on about the need to provide information for women living with brain metastasis. And Julia and Dr. Lin had many, many conversations about this and agreed to provide this webinar for you today. And we're so thankful and so happy that both of you are here with us today. Thank you for all the work that you put into this. Let me introduce you to Dr. Lin and then to Julia. So Dr. Lin is the Associate Chief of the Division of Breast Oncology at Dana-Farber Cancer Institute, the Director of the Embrace Metastatic Breast Cancer Program, and Director of the Program for Patients with Breast Cancer Brain Metastasis at Dana-Farber. She is an Associate Professor of Medicine at Harvard Medical School. Her research is focused on developing novel therapies for patients with metastatic breast cancer and in understanding mechanisms of therapeutic resistance. Dr. Lin has led multiple trials of novel systemic approaches for metastatic breast cancer, including patients with breast cancer brain metastasis. Julia was diagnosed with breast cancer in 2013 while pregnant. Following the birth of a healthy baby boy, Julia did tests she couldn't do while pregnant and discovered the cancer had already spread to her brain, liver, and bones. After many treatment setbacks, her cancer began to respond to a particular drug. While Julia will be on treatment for the rest of her life, she's still a dynamic and very kind 35-year-old woman living every moment. Although cancer is part of Julia's life, it doesn't define her. Julia works to make an impact in the lives of others living with MBC. She focuses on inequities in breast cancer treatment and information in underserved groups, and particularly metastatic patients with brain mets. Julia also works as a research advocate, working with researchers, clinicians, and other stakeholders to ensure research is patient-centered, innovative, and accessible. Julia is a member of Living Beyond Breast Cancer's 2018 Hear My Voice class. She's an Alamo Foundation Scholar, a DoD congressionally directed breast cancer research program reviewer, and an ASCO Guidelines panelist. She's a patient advisor to the LBBC Susan G. Komen DC Metastatic Breast Cancer Conference and to Teresa's Research Metastatic Breast Cancer Conference. And she's also a member of the Metastatic Breast Cancer Alliance. Welcome to you both. It's all yours.
Thank you. Julia, do you want to say a few words first, and then I'll go right into the talk?
Sure. Thank you, Nancy, for doing this for all of us. It's definitely a big need. We had a record registration for this webinar, and we absolutely look forward to seeing everything that you have put together, and also all of the changes that are coming in policy, including brain mets patients. And yeah, so definitely wanted to also include a message of hope in this. So Dr. Lin will talk about treatments, and one of the recurring themes is that brain mets is not a death sentence. It is a very complicated diagnosis. It will probably be what kills me one day, but at the same time, I never thought I'd be living for 6 years when I was first diagnosed, and I'm still here. So there are many stories like mine, and hopefully even more in the future with all the new treatments.
Great, thank you so much. So this talk really kind of is a team effort, and I hope that that will show as I go through the slides. So I'm going to talk today about the problem of breast cancer brain metastasis, and I'm going to review new and emerging treatments, and along the way we'll tell you some real patient stories as hopefully reasons to be hopeful. So in terms of what we'll cover today, I'm going to go through a few definitions. I'm going to make a few comments about prognosis. We'll talk about risk factors for the development of brain metastases and talk about common symptoms. And then we'll delve into the details about current treatment options, including clinical trials. At the end, we'll cover a couple of action items that you can take home as take-home messages, and then we'll open it up to Q&A. And the picture on the right is actually a picture of Julia. Obviously, we use with her permission, with her son, Max. And as you heard, Julia was pregnant with Max when she was first diagnosed with breast cancer. And I think it really is amazing to see him in 6 years old and in first grade today. Okay, so a few comments before we begin. This is clearly a hard topic, and it brings up a lot of emotions. And the truth is that even showing the best case scenarios, at least today in 2019, we still cannot cure patients with breast cancer brain metastases. I'm sharing some of the patient stories to give hope, but I also fully recognize that we have a lot of progress left to make, and I don't want to sugarcoat the reality, and I certainly do not want to minimize what patients and their families are going through. You've heard it before, but it really is true that every patient is different, and I'll show you some sense of that as we go through the patient stories. And finally, as you heard, I can't give personalized medical advice during this webinar, but what I hope is that you'll come away with the knowledge you need to be proactive and engaged in your health. So first, some definitions. So when we talk about brain metastasis, what we're talking about is breast cancer in this case that has spread to the brain. And this can appear as spots or tumors or lesions in the brain, and they often retain the characteristics of their original cancer. When we talk about something called leptomeningeal disease, that's abbreviated LMD, that's cancer that has spread to the fluid that surrounds the brain and the spinal cord, and it can travel both around the brain as well as up and down the spinal cord. Not forwarding here. Okay, so who develops brain metastases? Fortunately, it's not commonly the first place that cancer travels, but it can happen. It is more common in patients who have either HER2 positive or triple negative breast cancer, but they can occur in patients with any breast cancer subtype. We do see a little bit more LMD or leptomeningeal metastasis in patients who have lobular type breast cancer. That's usually estrogen receptor positive. And we also see, it looks like a bit more in patients with either BRCA1 or BRCA2 associated breast cancer. Many studies have shown that brain metastases are more common in younger women with breast cancer, but it's not clear whether this is due mostly because younger women tend to have more HER2 positive and triple negative breast cancers, or because there's something very particular about being young that predisposes. And as patients with metastatic breast cancer live longer, we are seeing more patients develop brain metastases, and we think that this is happening because our treatments are better at treating the disease outside of the brain compared to the disease in the brain, and people are living long enough that cancer in the brain is becoming a problem. So I want to just make a couple words about prognosis before we get into the nitty-gritty of treatment. And, when patients ask me, how long do I have, or what's the average, how long on average do people with, brain metastasis live? I think that one of the first visions that people have in their mind is basically a cliff, and that really no matter what time frame I give, whether it's 6 months or 2 years or 5 years or whatever it is, that I think people have this sense in their mind that at that time they're going to fall off a cliff. And what I will say is that this is really what the reality looks like. And so the arrow is kind of time, going from left to right, and the stars are how long different patients survive. And you can see, like, the arrow shows what the average is. So if you ask, what is the average, this is what you'll get. But the truth is that there are people who do worse than average, and there are people who do far better than average. And so average, you have to take that information with a bit of a grain of salt, because it doesn't really reflect in the way that people imagine that it reflects how individual patients do. This average is truly, it is an average, but as you can see, people do really very, very differently. And this is just an example to show selected patients that either Julia knows or I know. We've changed all the initials. I don't have a lot of details about the patients just to protect confidentiality, but just to illustrate how very different patients can be. So this is a patient who was diagnosed with HER2-positive breast cancer in 1998, developed metastatic disease in 2001, and was found to have brain metastasis in 2003. She was treated with SRS. We'll talk about what that is in a minute, but basically focused radiation. She's been on Herceptin, and she's been NED for now over 10 years. Here is a woman who was just recently diagnosed, or relatively recently diagnosed, about a year and a half ago, with estrogen receptor positive, HER2 negative metastatic breast cancer. And at the time that it was diagnosed, it already was metastatic, including with leptomeningeal disease. She's received radiation therapy. She started on hormonal therapy. It worked initially, stopped working. She's now on chemotherapy and actually responding. It's obviously early time frame for her, but I think we'll show, as we'll talk about later, that chemotherapy can be helpful in some patients. Here's a woman who had initial diagnosis of triple-negative breast cancer in 2013, developed cancer recurrence in her lung and brain, has received now focused radiation treatment, surgery, and is now receiving chemotherapy. And I think that what you can see across all of these patients is that people are living for varying amounts of time, but there are people who are able to live for many years after a diagnosis, even of brain metastasis. And you can also see kind of the variety of treatments people receive, really illustrating that this is a type of problem that requires us to really go outside of medical oncology and involve all sorts of different specialties to make sure that we provide patients with the best possible care. So just in terms of prognosis, to finish up this discussion, many, but unfortunately not all, patients with breast cancer brain metastases are living longer than ever before. And if you are comfortable asking about prognosis, I think it's important to share with your providers if you want to know, how you want to know, when you want to know. And if you're comfortable, the kinds of things that you can ask are, what is the chance I'll be alive, and then pick a time frame. Have you ever seen anyone get out to 3 years, 5 years, etc.? Is it realistic to hope for? And then you fill in the blank. And it's fine to ask people what makes them think, what makes them tell you what they are telling you. How do you know, and why do you think so? All right, so now we're going to move on to symptoms. And so these are some of the more common symptoms that we see. And of the symptoms, in terms of patients with brain metastasis, by far the most common is headaches. Of course, headaches are a very common symptom that people have in everyday life. And so one of the jobs that we have as oncologists is to try to ask follow-up questions to understand if there's something about the headache that makes us worried enough that we should prompt a scan to understand whether there's anything going on in the brain leading to the headaches. Other symptoms that we look for are nausea or vomiting that we can't explain with chemotherapy side effects, Seizures, they're not actually very common, as it turns out, as an initial symptom, but they can happen. Weakness or numbness, especially if it's on one side versus the other. Imbalance, falls, or loss of coordination. Changes in vision. And then for patients with leptomeningeal disease, we worry when people come in with confusion or back pain or problems with their bladder or bowel function. And if you have these symptoms, it's really important to let your medical team know. Obviously, many patients who have these symptoms do not have brain metastases, but regardless, they're important symptoms for your medical team to know about because these are symptoms that we would want to work up and understand better and try to treat better. There are many ways to treat patients with brain metastases, and I'm going to focus on three major types of treatment: surgery, radiation therapy, and then systemic therapy. And by systemic therapy, I mean treatments that get through the entire body, and so those include things like chemotherapy, targeted therapy, or hormonal therapy. At every decision point, as you can see, we really weigh all of the different options, and I personally myself actually have a checklist in my mind, and I am very rigorous about checking off every possibility because I just want to make sure that I'm exploring every approach at every decision point. And sometimes the answer is no, this is not an option, but it's important, I think, to be very systematic about it. So I think about whether surgery makes sense, whether radiation makes sense, what are the systemic therapy options, what are the clinical trials, and what does the patient want, and what are their preferences and values. So you can see from this right off the bat that really having a well-functioning team is absolutely critical. People have to talk to each other. You need to have people with expertise in each of these areas. And I very much include patients as part of the team because that's really the reality in a well-functioning team includes a patient. So when and why do we consider neurosurgery as one of the first, one of the options? This picture can be hard to see, especially if you yourself are calling in and you've never had brain surgery. It's hard to see a picture like this, but I will tell you that this is actually a Julia, and she provided this picture, permission to show this picture. And this is a picture of Julia after she had her brain surgery now 4 years ago, and you've seen that she's doing very well now. When we think about putting patients through something quite as major as brain surgery, really what we're wanting to understand is, what is the benefit of it? Because, of course, there is some risk. So the time that we consider surgery are patients who have a single brain metastasis. There are randomized clinical trials that show that patients who have the area of cancer removed surgically in the brain actually experience a survival benefit. They live longer than patients treated with radiation alone. So for patients who are good surgical candidates who have a single area in the brain, we do consider surgery. We also consider surgery when the diagnosis is in question. So sometimes patients have no other sites of cancer, and we're trying to understand what kind of cancer they have, or the area in the brain looks a little funny for breast cancer. We want to be sure that we know what we're dealing with. Sometimes there's a situation where patients have had radiation and there are symptoms related to swelling around an area in the brain, and we're not sure whether those symptoms are because of a radiation side effect called radiation necrosis or whether it's progressive cancer. And it's important to find that out because if we radiate radiation necrosis, we're not going to make it better. And finally, there are situations where patients might have several have had different types of breast cancer, have had both an estrogen positive and a HER2 positive breast cancer or triple negative breast cancer, and we don't know what cancer actually traveled to the brain. And there it's important to understand that because that will very much determine treatment options. Sometimes patients have multiple areas in the brain, but there's one in particular that's really causing problems, and we might take somebody to the operating room just to deal with that one surgically, and the others could be treated with radiation therapy, for example. And in general, we are trying to consider neurosurgery for patients who have controlled or controllable disease outside of the brain, and in patients who are healthy enough to tolerate surgery. There have been a lot of advances in neurosurgery, and it's the reason why going to a center which operates on a lot of patients, has very high volume, is so important and has very good surgeons. Some of the advances are just shown here, and they include things like functional MRI. So they will have you go in an MRI machine and do certain things while you're in the machine, and they can actually map what parts of the brain are controlling those actions, and that allows the surgeons to stay away from those areas of the brain when they do your surgery. There is intraoperative MRI or 3D navigation systems, and this picture just shows, the sort of very high-tech nature of neurosurgery operating rooms these days, where there is very, very precise localization of the cancer to help guide the surgeon in real time. There's intraoperative monitoring, so there's also something called awake surgery. So if a tumor is close to the part of the body, for example, that controls speech or controls motor function, that they can actually ask you to do certain things during the operation, and that helps them, again, keep away from the vital structures as they're taking out the tumor. And then there's a newer procedure called LIT, which we're still learning more about, but is something that is now on the table and is something that could be considered in select circumstances. So just to show you an example of a patient, this is a patient who had ER or has ER-positive brain metastasis, originally diagnosed in 2013, 2 years after she had an original stage 2 breast cancer diagnosis. So she's had actually all of these various things. She had surgery, she's had SRS, and we'll talk about that next, and then most recently has had LIT for what turned out to be radiation necrosis. So I think just, again, to illustrate that we really have a lot of tools at hand, and the trick is really trying to figure out when to use what. Now moving on to radiation-based approaches, the two main radiation-based approaches that we think about are whole brain radiation therapy and stereotactic radiosurgery. So whole brain radiation therapy basically delivers radiation across the entire brain. As you can see, the radiation oncologists try to avoid the eyes and the optic nerves, but they really are trying to treat the entire brain. And the advantage is that this allows the radiation oncologist to treat not only the areas that you can see with cancer, but even microscopic areas of cancer in the brain. And it has been shown that giving whole brain radiation does reduce the chance of new areas showing up in your brain, although there are side effects, as we'll talk about. Stereotactic radiosurgery, how that works is that there are beams that go across in multiple directions, but they all add up in terms of the dose in specific locations of the brain. And this allows the radiation oncologist to give very high doses of radiation, usually in a single dose, to multiple spots in the brain while avoiding as much of the normal brain as possible. In terms of comparing and contrasting, again, whole brain radiation treats the entire brain. We can treat many lesions at a time. It does lower the chance of subsequent new brain metastases, but the thing that we worry most about with whole brain radiation therapy are the effects on tiredness and fatigue, which can last for several months, and then long-term, the effects on thinking and cognition. In terms of SRS treatment, it's focused treatment of visible lesions. It can be done much more quickly in 1 day as opposed to 2 to 3 weeks with whole brain. There's faster recovery, but we do worry more about the development of new brain metastases that we didn't see on the scan and that we're not targeting. For patients in whom whole brain radiation therapy is recommended, of course, this is an area that people worry, understandably, very much about because nobody wants to have problems in terms of their thinking ability. And here there is some good news. There have been 2 major advances over the last few years that allow us to protect the brain better during whole brain radiation therapy, and they are this pill called memantine, and then a technique which is called hippocampal avoidant whole brain radiation. So memantine is a drug that was originally developed for dementia, and what has been done is a phase 3 trial where patients who were started on whole brain radiation treatment started also at the same time on memantine pills, and this was continued then after radiation for about 6 months, and patients were asked to do very rigorous assessments of their cognitive function. They had to do these cognitive tests. And what was seen is that people who received memantine did better on the cognitive tests at 6 months compared to patients who did not receive memantine. And this did not compromise the effectiveness of whole brain radiation therapy. So that has definitely entered as part of one of the standard things that we offer to patients today. And then there is something called hippocampal avoidant whole brain radiation therapy. And what this is that the hippocampus are these areas in the brain, they're shown here, which help with memory. This is the part of the brain that's affected in patients who have Alzheimer's disease. And it's very, very rare that cancer from breast cancer goes to the hippocampus. That is exceedingly uncommon. And so what happens is that this is a form of whole brain radiation therapy where the hippocampus is purposely not irradiated to the same level. And recently we saw results of a phase 3 trial showing that by using hippocampal avoidant whole brain radiation therapy, the patients actually do better on the neurocognitive function testing. There's less patient symptom burden, and this does not seem to compromise the effectiveness of radiation therapy, and there's no worsening or impact on overall survival. If whole brain radiation therapy is not necessary, we often will look at focused radiation approaches, and a few of the names that you might have heard about are here. And really the commonality is that they're all focused radiation approaches, whether it's SRS or gamma knife or cyber knife. Stereotactic radiotherapy is similar, but it's basically given instead of over 1 day, it's typically given over 5 days. And the reason for that is that when we treat large areas in the brain or areas that have had previous radiation, it can be safer to give the radiation split up over a couple of days rather than a big dose all in 1 day. There have been a number of advances in radiation approaches over the past years, and that includes something called frameless SRS, which is treatment that does not require a metal frame to be placed on somebody's head, and that's certainly a major advance in terms of quality of life. In addition, there is something called single isocenter treatment, and what that means is that rather than having people come in multiple days to treat 2 lesions here and 2 lesions there and another 1 lesion there, that all of the lesions often can be treated in a single day, which makes it much more convenient and also much more possible for patients who travel to academic centers to go there for their 1-day treatment. And there's improved monitoring systems to make sure that the plan and the actual treatment match up as best as possible. So this is just an example of somebody who received a focused radiation approach. This is a woman who was diagnosed with stage 3 HER2-positive breast cancer while she was 34 weeks pregnant back in 1998. In 2001, she presented with metastatic breast cancer, and in 2003 it was found to have traveled to her brain, and she was treated with a gamma knife. This is a picture that she's provided with permission to show this to you today. This is her on the day of her SRS or gamma knife treatment. And again, now we have frameless treatment, so patients no longer have to actually wear a frame like this. And this is her recently with Julia. And amazingly enough, you can actually see her daughter here, who she was pregnant with in 1998. What about treating patients who have multiple brain metastases with SRS? Because traditionally, the more metastases were present in the brain, the more we lean towards whole brain radiation therapy. But even with the advances that we've seen with whole brain radiation therapy, we still worry about the side effects. At the same time, you can imagine that if somebody had 50 areas that we were going to spot focus radiation, it starts to get pretty close, if not exceed, the types of radiation doses we would give with whole brain. And so there really is this uncertainty in patients who have multiple lesions. Is SRS really better, or should we really just be doing whole brain with the extra bells and whistles that I talked about? So there is a clinical trial ongoing that's open in both Massachusetts and Rhode Island that's directly comparing whole brain radiation with SRS in patients with multiple brain lesions, and it's being led by my colleague, Dr. Ayel Azer. Now I'm going to move on to systemic therapy. And, the old assumptions had been that systemic treatments don't work in the brain, and that the only thing that we have is radiation and surgery. We now know that this is not true, that systemic therapies can be effective, but we also recognize that we need to invest more in developing and testing them and focusing on patients with active brain metastases. So the new approach is to consider systemic therapy as one of many options on the table. It's not always the right option, and we always think about local therapies, but it becomes one of the options that's on the table and something we discuss in a multidisciplinary way. Chemotherapy or hormonal therapy can, in fact, be effective in some patients. I have a list here of some of the drugs that we're most familiar with in terms of their activity in the brain. And they include medicines that we use commonly in breast cancer, like capecitabine or carboplatin or adriamycin or Doxil, as well as some chemotherapies we don't use as much in breast cancer, like irinotecan. And hormonal therapies also can work in the brain as well, although for many patients with estrogen-positive breast cancer, by the time the cancer has traveled to the brain, patients often have disease that has become resistant to these treatments. But if a patient has never had hormonal therapy, certainly this could be considered. And on the right, I just show a picture of a patient we treated at Dana-Farber with capecitabine or Xeloda, just showing that there really can be responses in the brain that can last for many months with chemotherapy. And this is just another example. And again, I don't want to sugarcoat the situation. And this patient has a very unusual course, but it's important to know it's possible. This is a woman who was diagnosed with her metastatic breast cancer in 2014. At the time when she was diagnosed, it was involving many parts of her body, including her brain. And actually in her brain, the areas of cancer were quite small. They were not causing a lot of symptoms, but the other areas of cancer were rapidly growing. So even though normally we would start with radiation to the brain, in her case, for all of these reasons, her doctor started her on chemotherapy. She started 2 cycles of carboplatin chemotherapy, and then she was rescanned with the idea that if the areas of cancer in the brain were not better, she would go to radiation at that point. But amazingly, she actually had significant improvement in both her brain and her body, and she has now been NED for about the last few years, just being observed. I will tell you that there are many clinical trials now that are testing what we hope to be new and better chemotherapy drugs that get into the brain better, that have different properties. And I just show a couple of them here. This is not a complete list, but just to show you some of the compounds. Nectar 102 it uses this chemotherapy called irinotecan, which is something that is commonly used for things like colon cancer, patients with colon cancer. But it's been chemically modified, so it stays in tumors longer and also seems to accumulate better in the brain metastasis. And now Erie, again, is also based on this irinotecan chemotherapy, and it's a so-called liposome. So a lot of irinotecan molecules get packaged in this lysosome, and the hope is that it would get better into the brain and stay there better. And these 2 compounds are already in clinical trials. The Nectar 102 is in a phase 3 clinical trial for patients who have stable treated brain metastases. The now Erie is just coming out of phase 1. And then there are some ways and attempts to try to improve on Taxol, which we commonly use as a chemotherapy for breast cancer. Ang-1005 is Taxol that is chemically modified, so it has this little tag. And what the tag allows it to do is take advantage of the body's natural mechanisms. So actually across the blood-brain barrier, it's able to stick onto this molecule called LRP, and that actually shuttles it actively across the blood-brain barrier where it gets into the brain. And the tumor cells also have LRP, and then they just take in the compounds. It's a way of getting active drug into the brain, and there will be a study opening with this compound for patients with leptomeningeal disease. And then Taxol is a taxane, so it's related to Taxol or Taxotere. But what's different about it is it's not a so-called PGP substrate, and that means that it can get into the brain very well. And I'll show you later that there are some ongoing trials with Taxol. Now I'm going to move to HER2-targeted treatments, and this is an area where I think there has been a lot of research focus placed. And there are now several options that are available to patients, and one that may come soon depending on results of an ongoing clinical trial. The first I'll tell you about is called Lapatinib or Tykerb. I'll talk about Neratinib and something called TNBC or Kadcyla. And then finally we'll talk a little bit about this drug Tucatinib. So we and others looked at how well Lapatinib, which is an oral HER2-targeted treatment, works in patients who have cancer that has spread to the brain. And when we combine it with capecitabine chemotherapy, what we see, and this shows the chance of tumor shrinkage in the brain, is that in patients whose cancer got worse after previous radiation therapy, about 20 to 30% of the time we do see tumor shrinkage in the brain with this combination. And in patients who've never had radiation before to the brain and want to avoid radiation, it works about 2/3 of the time. This is certainly promising, but 20 or 30% is nowhere near 90%. And can we get better? Other drugs that have been looked at, one is called TDM1 or Kadcyla. We've assumed for a very long time that because TDM1 is a so-called monoclonal antibody, that it would not work against brain metastases, since we assumed it just would not get in. However, since then, there have been multiple very convincing reports in the literature that TDM1 can actually work in the brain. And these are pictures from 2 patients that were reported out earlier. This is a patient, as you can see, who had an area of cancer in her cerebellum, and you can see how much improvement there was after the TDM1. And similarly, this is a patient who had an area of cancer higher up in the left side, and you can again see an improvement with TDM1. These are patients who did not receive radiation to get this improvement. This improvement is attributed to the treatment. And then finally, in terms of other HER2-targeted treatments, is this drug called Neratinib. Right now, Neratinib is approved by the FDA only for use in patients with high-risk early-stage breast cancer. However, it is commercially available. And what we looked at here, and this is a study led by my colleague Rachel Friedman, is looking at patients with HER2-positive breast cancer brain metastases, treating with this combination of 2 treatments. And the way that you read these graphs is that every line represents 1 patient. So this is a patient who the treatment didn't work in, the cancer grew. But you can see all of these patients who experience tumor shrinkage in the brain with the combination treatment. And overall, if you set 50% as the threshold for saying there's a significant shrinkage, 50% of patients made that threshold, but you can see there are more who also were close and didn't quite make that threshold, but still did have benefit from the drug. So the combination of Neratinib and Capecitabine is now listed in the so-called NCCN treatment guidelines. And this is important because these treatment guidelines are often used by insurance to determine whether or not medications will be covered. So many insurers are now covering the combination for patients with breast cancer brain metastases. And the clinical trial is now opening up additional cohorts of patients. And so you saw the data for TDM1 and you saw the data for Neratinib, so it makes sense to combine them, and that's what's being done in the current study. And finally, to tell you about this drug called Tucatinib, which is up and coming. This was the phase 1 study that combined Tucatinib, which is a HER2 drug, Capecitabine, which is chemotherapy, and Herceptin. This is the same type of plot showing the response or the tumor shrinkage rate outside of the brain, 60% in patients who had received a lot of previous chemotherapy and Herceptin. And in a small group of patients who had cancer in the brain, you saw that over 40% of patients did experience significant tumor shrinkage. So there's a randomized trial that's just finished recruiting patients. This is a trial that enrolled patients with HER2-positive metastatic breast cancer. Patients were randomly assigned either to get Herceptin and Xeloda as standard of care, or they received Herceptin, Xeloda, and Tucatinib. And we are just awaiting results of that study. Hopefully we shall see them soon. And if it's a positive study, I think could add another treatment option for patients. There are many, many other interesting targets and drugs that are currently in active development, including medicines that target blood vessels, medicines that target CDK4/6 like abemaciclib or palbociclib, medicines that target this pathway called PI3K/mTOR, immune-targeted medicines, and even PARP inhibitors. And this is not even a complete list, and I hope will just show that there's an enormous amount of activity in this area, and people really do want to solve this problem. So in the last few minutes, I want to make a couple comments about clinical trials, and then we open it up to questions. So clinical trials are how we learn about side effects and possible anti-tumor activity of new treatments. And the good news is that there's an increasing number of clinical trials for patients with brain metastases. The bad news is that there's not nearly enough. And so there are many, many national efforts. Julia and I have been involved in them to increase the inclusion of patients with brain metastases into clinical trials. And there are clinical trials testing not only new chemotherapy targeted treatments, but also testing new surgical or radiation approaches. This is an example of a patient who's been living with HER2-positive brain metastasis since 2013. She initially was treated with the usual radiation-based approaches, but they started to not be enough. And she has now been on a number of different HER2-targeted treatments, including 2 clinical trials. I'm going to just show a couple examples of ongoing clinical trials. This is by no means complete, and there are many more trials available, but I just wanted to give you a flavor of some of the things that are being looked at. So this is a national trial which is enrolling patients who have either triple-negative breast cancer or breast cancer that is associated with a hereditary or inherited BRCA1 or 2 gene mutation. The trial assigns patients to either receive cisplatin chemotherapy or cisplatin chemotherapy with a PARP inhibitor. And again, this trial does allow patients with brain metastases to enroll, and it is enrolling nationally. What I've done at the bottom is put what's called the NCT number, and if you cut and paste this and put it in a web search, it'll automatically show the entry for the study as well as all the places that the study is open. For patients who have leptomeningeal disease, which is HER2 positive, there is a trial that is ongoing within what's called the Translational Breast Cancer Research Consortium. So again, this is a national trial. All patients in this trial receive the 3-drug combination of tucatinib, capecitabine, and trastuzumab. Patients have to have untreated leptomeningeal disease in order to enter the study. And I encourage, if you do have leptomeningeal disease, this would be a good study to think about. The TPCRC also has, as I showed you before, an ongoing trial for patients with HER2-positive brain metastases, and the trial is currently looking for patients who have either had TDM1, never had TDM1, had radiation, or never had radiation, so it's fairly open. And the combination that's being tested here is the combination of TDM1 plus neratinib. This is not a randomized trial, so everybody who qualifies for the study and wishes to enter would receive both drugs. And finally, for patients who have either estrogen receptor positive or triple-negative brain metastases, there's a series of so-called Contessa trials, which is looking at this new taxane-type chemotherapy medicine. These trials are limited to patients as their first chemotherapy for breast cancer, for metastatic breast cancer, so it is a bit more limiting in terms of who is allowed on the study. But all of the 3 studies do allow patients with brain metastases to enter. And I'll point out that the Contessa Trio study, which is enrolling triple-negative breast cancer patients, includes immunotherapy. So how do you find a clinical trial? I think that there are a number of ways, but I think that the most helpful ways I've found are to talk to your doctor, to seek a second opinion, to talk to other patients or patient advocates, and then there are a number of websites that can be very helpful. And I've just shown a couple of them here. I'll just point out, for example, that brainmetsbc.org has a page on their website that collates the trials for patients with brain metastases and trials for patients with leptomeningeal disease, and they try to keep this updated, and I found it to be a very useful resource. When patients fly from other parts of the country to see me and they want to know if there's a trial open near close to them, or if a particular university has a study open, this is one of the places I go because it's really very convenient and puts everything in one place. Share Cancer Support, NBC Alliance, and others have nice web-based engines to help you search for clinical trials. And then once you have the search output, you can certainly bring them to your doctor and help sort out the things that may be possible and the things for which you're not eligible. What gives me hope? What gives me hope is that I see, and it's not everybody, but it's some people living longer and better with brain metastases in a way I really used to hardly ever see. And I know it's not enough, and Julia knows it's not enough, but it definitely gives me anyways hope that we are making progress. I see that the pace of scientific and technological advances is just faster and faster. Ability to understand what's going on in the cancer to understand what's going on in the genes, to understand what's going on in the immune system, to develop better drugs. It's just getting better all the time. There are definitely more people who are focused on this problem in the lab and in the clinic. And over time, what I'm hoping is to see even more inclusion of patients with brain metastases in clinical trials, because ultimately that's how we translate laboratory findings into treatments that are meaningful for patients. So the last slide I have is just some action items, and I think that you're already here on this webinar and you're educating yourself, and that's really important. As you probably have gathered from my presentation, it's so very important to have a strong multidisciplinary team for your care. No one expects you to be your own doctor. That's what we are here for. But it's really important to make sure that you feel a part of your team and that your team really works well together. It's always an option to consider a second opinion. My own patients sometimes seek second opinions. It's really not a matter of feeling like you're going to disappoint your doctor, or your doctor feeling like they don't trust you. It's really a matter of just getting your options and understanding what's going on. And sometimes hearing a second opinion is very helpful and can turn up additional options for you. Ask about clinical trials. It's just really important, if you're interested in clinical trials, to make it known to your medical team that you're interested. I've certainly seen people whose doctors have assumed that because they have 2 young children and the nearest clinical trial site is 100 miles away, that they're not going to be interested in trials, and they're not even approached about trials. And so I think it's just really important, if you're interested, to ask. And finally, if you're comfortable with it, advocate for inclusion of patients with brain metastases in clinical trials. Certainly Julia has done very much work on this behalf. To be visible, because the more visible people are, the more it becomes really apparent that developing better treatments for patients with brain metastases is just so very critical. So that's all I have to say. Thank you, and I think Julia is going to moderate the questions.
Thank you, Dr. Lin. Julia?
Yes, thank you so much, Dr. Lin, for this great presentation. So I'm going to, I have combined a few questions that different people have asked, and I'll try to cover them. So one of the first questions we got is about repeat radiation, and if you can do stereotactic to the same area, if you can do stereotactic to a different area, if you can do whole brain again, if it's been a while, and all of those.
Sure. So if somebody has had whole brain to start with, it almost always is possible if, let's say, a few spots subsequently get worse or appear as new spots. It's almost always possible, with few exceptions, to do SRS-based treatment. If somebody has had SRS-based treatment to a specific spot, sometimes it's possible to re-radiate the same spot with SRS. It really depends on the location and how sensitive it would be to repeat doses of radiation and how much radiation exposure was to begin with. And it's the reason why when you see a radiation oncologist, they need not only the reports of the treatment, but the actual treatment planning films, because then they can actually see the dose that was received to each of the spots. They map it out, and they determine what the tolerance would be for additional radiation. We try not to give whole brain radiation twice, because we worry even more so about the side effects. We really reserve that for pretty unusual situations where there's been a reasonable amount of time between radiation treatments and where we're really stuck in a very difficult situation.
Okay, the next question is about clinical trials, and maybe I'll just say a few things just as a patient and an advocate. So if you think that you're not interested in clinical trials right now, even before you've heard about one, just reconsider that position, especially in the United States. The worst that you're going to get is the standard of care. So you're not going to get a sugar pill those things are not allowed in this country, and it's very important to consider clinical trials, because that's really how we're going to get the latest drugs that are going to work in the future to be used by you today. I'll add another resource that to that list of places to look for trials. The clinicaltrials.gov website is overwhelming, and it's very hard to put that responsibility on the patient to look for it. One resource specifically for metastatic breast cancer that works very well and that is updated frequently and that people have found to be very helpful is the website thestormriders.org, which is maintained by another patient
advocate. Oh yes, I should have included that. It's a great website.
Yeah. So yeah, it's a very good website. But you always have to have those conversations with your doctor, and I'll add that if you have a brain mets diagnosis, you will likely have multiple doctors, not only if you seek a second or third opinions, but also you'll be seeing a whole range of specialties. So you'll be seeing a radiation oncologist, like Dr. Lin said, that's a common member of your team. And then depending on if you're going to do surgery, you might have a neurosurgeon, you might have a neuro-oncologist. So it really becomes a team effort at that point. I don't know, Dr. Lin, if you have anything to add about trials and finding trials and
Sure.
considering trials.
Yeah, I think for trials, I think it's important to recognize that there's more than one kind of trial. And so there may be trials that you feel less or more comfortable with, but not all trials are the same. So if we think about phase 1 trials, they're usually the early trials when we're looking at new drugs. But phase 1 trials could be you're the first person in the world to receive this drug at the lowest starting dose, or we've already seen in a previous phase 1 that it works in breast cancer patients, and now we want to enroll more breast cancer patients to better understand how well it works, and already 500 patients have been treated. So I think, if you are approached about a phase 1 study, not all phase 1 studies are the same. When we think about phase 3 studies, typically phase 3 studies are the latest phase before a drug gets approved. And those studies are often randomized trials. So they're studies where you don't necessarily know going into the study which group you will be assigned to. However, what is true is that at least for patients with metastatic breast cancer, we really do not have trials where you're assigned to nothing. So there might be a trial where you assign to standard chemotherapy or the study drug, or there may be trials where you get standard chemotherapy in one group and standard chemotherapy plus the study drug in another group. But in any case, the so-called control arm, the arm that's not necessarily getting the study drug, always has to conform to what we consider a reasonable standard of care. And so I think that, again, when you're thinking about clinical trials, I think, they're not always right for every person. They're not always right at every time point. But I would encourage people to keep an open mind and to hear about what that option is at that one point in time.
Okay, so we'll take a little bit of a turn now and think about imaging now. So there are a few questions surrounding imaging. First, we'll talk about once you already have established brain metastasis, or, well, actually that's a question by itself. It's really hard to establish the brain metastasis because the brain is not an organ that you can easily biopsy.
Right.
So maybe Dr. Lin, you can talk a little bit about screening and
Sure.
when to look for them, if you do it before or if you wait for symptoms. And then the second question, and I'll just add on to that, will be about once those are treated with radiation, how to differentiate in additional scans after the treatment, how to differentiate new tumor from necrosis.
Yeah, good questions. So as far as the first question, and I have backup slides just in case because I thought the question would come up, is, why don't we, the truth is, at least in the United States, we don't typically routinely screen patients for brain metastases. Screening meaning somebody does not have brain metastases, does not have any symptoms. We generally are not ordering MRI scans of the brain every time somebody has a CAT scan of their body. And the reasons for that are that although early treatment or early detection of brain metastases might be helpful, it's also possible that because the treatments for brain metastases cause short and long-term side effects, that you end up doing a disservice by finding them earlier, because it's possible that they could have been well treated with whatever systemic therapy the patient is on. And if the brain scans are not timed with body scans, their meaning can be hard to interpret, and sometimes they can cause people to come off of clinical trials unnecessarily. In addition, right now, unfortunately, although the culture is changing, the presence of brain metastases still can affect clinical trial eligibility. And finally, there has not yet been a study that has definitively shown that screening is useful. All of these things are things that we should address, and we are trying to address. Obviously, if we develop treatments with fewer side effects, that's going to knock out this first objection to screening. The second is that if we are going to do screening, it really needs to be timed properly. So, for example, when people are having staging scans anyways of their body, so that we can really interpret what they mean. We should be advocating for the inclusion of patients with brain metastases in clinical trials. We really shouldn't be not screening because we're worried they're going to affect trial eligibility. We should just change the trial eligibility. Mm-hmm. And finally, there has not been a study definitively showing a benefit, but that's because there has not been a study done. And so Dr. Azer at our institution just literally launched this past week a clinical trial, which is looking at patients starting their first or second chemotherapy for metastatic breast cancer, and patients are going to undergo brain MRI screening basically at the beginning, and then at the next time the cancer worsens in their body, we'll do an MRI as well. And that study actually is also testing a 8-minute MRI protocol. So rather than being in the machine for an hour, people are in the machine for less than 10 minutes. So we're really excited about this study. We are looking at the impact of screening on neurological quality of life. I think that if we do show a benefit, which we don't know that we will, but if we do show benefit, that will change how we take care of patients.
Yeah, no, so the brain MRIs, sitting in that machine or laying in that machine for 40 minutes with those loud noises is, I've
really
over
hard.
the years have learned to really meditate during that time, but it has taken me a long time.
Yeah, I know. And then so the second question that you had was about,
radiation necrosis.
Right, exactly. And so there's not a perfect test is the problem. And a lot of what we do is based on clinical judgment. It's based on sometimes we're not sure, and then we'll repeat a scan. Sometimes we're not sure, and we might do other types of scans like a PET or a SPECT. But there is the only so-called gold standard, the only test that tells us for 100% sure is taking somebody to the operating room or moving the area. We do sometimes do that if the area is causing a lot of symptoms and we're not sure what's going on. But this is an area of a lot of research because we really do need to develop better tests, and we don't have them right now.
Okay, so we got a few questions about some of the newer, especially ER-positive drugs, the CDK4/6 inhibitors and the PIK3 inhibitors.
Yeah. Okay. So for estrogen receptor positive breast cancer, there was a study that was presented at our ASCO meeting earlier this year that looked at the CDK4/6 inhibitor abemaciclib for the treatment of patients with cancer in the brain. And what that study showed, the study was aiming higher, but ultimately what it showed was that the chance of significant tumor shrinkage was only, it was actually less than 10%, although there were patients who had tumor shrinkage in the brain with abemaciclib. However, there were also patients who they didn't have necessarily significant tumor shrinkage, but they had some tumor shrinkage, or they had prolonged stabilization of the cancer in the brain. So I think the study was kind of like a single, from a baseball analogy standpoint, there's something there, but it wasn't quite enough to say that this is like a really good treatment for brain metastases in most patients, although it's a okay treatment in some patients, and in some patients it was actually a very good treatment. So I think the next paths are really to understand, who gets the most benefit out of it. For the patients who got a little benefit, can we make it better? And for the patients who got no benefit, are there other combinations that we can think about? And so combinations that are currently under discussion are, could we combine it with immunotherapy? Could we combine it with other types of newer types of hormonal therapies? And I think these are trials that hopefully we'll start to see in the next year or two. The other area in terms of estrogen positive breast cancer is this whole issue of the so-called PIK3CA mutations. This is a gene that's found in about 1/3 of estrogen positive breast cancers, and there was a drug called Piqray approved by the FDA earlier this year for patients whose cancers have that mutation. The clinical trial that led to the approval did not include patients with active brain metastases, so right now we don't really know whether it works in the brain, although I suspect that it may. And there are some clinical trials, not of Piqray to my knowledge, but of similar compounds. We have one at Dana-Farber. There are others that will open at other places that basically are looking at similar drugs and seeing whether they might cause tumor shrinkage in the brain, especially in patients with PIK3CA mutations, but even in patients with just regular estrogen positive breast cancer.
So Julia, Dr. Lin, I think we're out of time. If you have any closing remarks.
No, I'll just say something that someone wrote in a question, and I thought that was excellent, that clinical trials are opportunities and they're not the last ditch. So we're really, the drugs of today exist because someone enrolled in trials in the past. So
I agree. And my last statement, and Julia and I had talked about this before, is, how do you even go about finding, if you are thinking about a second opinion, how do you go about finding a place that you want to go to? And, I was saying that there's actually a lot of centers in the United States, not as many as there should be, but who have doctors who are very interested and very experienced in treating patients with breast cancer that has spread to the brain. We have a center, Mass General has a center, Duke has a center, MD Anderson has a center, but there are many others. I think that the places to start are to talk with your doctor and get their advice. And then honestly, many advocacy organizations, including the ones that, sponsored today's webcast, like SHARE, they really have actually really, really strong networks and can be very helpful in guiding people to centers of excellence. And so I think, there's help out there, and you don't have to just Google search and find things on your own. There are definitely people who want and will help.
And I would just like to say that someone asked, how could they become an advocate? And at the very least, you can reach out to one of the organizations, SHARE, cancersupport.org, Living Beyond Breast Cancer, lbbc.org, Young Survival Coalition, youngsurvival.org. We each have different programs that you can participate. You could be trained as an advocate. You could be trained as a volunteer. You could attend one of the many conferences that are put on around the country. Now you can reach out to any of the organizations. We could put you in touch with advocates and get you started on your advocacy journey. So on behalf of SHARE, Living Beyond Breast Cancer, and the Young Survival Coalition, thank you all for your participation. If you have a moment, just fill out the survey at the end of the webinar. It helps to inform future webinars and lets us know how we're doing. And a very special thanks to Dr. Lin and to Julia for the benefit of your time, your expertise, your passion. Thank you both so much. We really appreciate it.
Thank you.
You're welcome.
Thanks for organizing this. Yeah.
Thanks, everyone. Bye-bye.
Bye.